Good morning, everybody. Welcome to Ramona Rounds. This month we have our presentation from the Medicine and Psychiatry Division for Ramona Rounds. This will end up being probably a series of very short talks. And we'll discuss the team-based approach that we use within the MIPS division on the inpatient and outpatient side. As a reminder for those on Zoom, please use the Q&A for any questions during the presentation and leave the chat function free for our broadcast staff. So today we're going to hear brief presentations from, well, basically our whole team. Marsha Wittink, the academic chief of the division, Kevin Brazill, the clinic director for outpatient MIPS. We'll have some presentation from nursing, including Stacey Castelluzzo, Carrah McAlees, and Jackie Mickol. We have a discussion of resident contributions from Tessa Oliver and Paul Kim, two psychiatry residents, and Elaine, you're doing the case, right? The case presentation from Elaine Rigney, MIPS clinician in the outpatient clinic. And so with that, I'll get out of the way.
Well, thank you all for coming out and listening. So last year, so I think everybody knows for Ramona Rounds, each division typically does a talk about their services. Last year, we talked primarily, actually, Dr. Harris and several of the team from G92, which is the Summits unit, talked. So today, we will review a little bit of what Summits unit is because it's part of our division, but we're going to focus more on Unit 192, which is our Medicine and Psychiatry inpatient unit, and the outpatient primary care practice, which you heard Dr. Brazill is the director of. So we're going to, hopefully this will all tie together and not feel too much like short presentations, although we have several different speakers to keep you awake, hopefully. All right. So that's why we call it team-based. A biopsychosocial approach is sort of the thing that overlies all of the work that we do in all three of our settings. And so I just kind of wanted to start with, why do we have this division of medicine? And putting in a plug as a reminder, yes, we are medicine, even though we pretend we are psychiatrists on TV sometimes. And we do have folks who are dual boarded in medicine and psychiatry, but we are primarily medical providers who do care here in the Department of Psychiatry and even on the side of the psychiatric hospital. So it's quite unusual. There are not a lot of hospitals that have a facility or have facilities like this. So why do we have it? Any thoughts just from the audience? Why would a Department of Psychiatry need a medical team to care for patients with psychiatric illnesses? Why wouldn't we just use the hospital medicine team and have consultants? All right, I'll let you think about it if you don't want to shout anything out. So here's one reason. We know that patients with especially severe or serious mental illnesses like schizophrenia and bipolar disorder they face really significant disparities, right? They're dying anywhere from 15 to 30 years earlier than the population of patients who don't have those severe mental illnesses. And that's obviously due to a variety of reasons. A lot of people think, oh, it's because of the psychiatric medications that can cause metabolic syndrome, antipsychotics, or it's because of lifestyle, right, smoking. So those things certainly contribute, but it turns out there's probably a lot of other really important factors. And some of them are things that we can modify within the health system and how we deliver care. And so that's why we really have these services here, is we've been able to see and learn that there are ways of approaching patients with severe mental illness and incorporating their medical care together with their psychiatric care that can improve those outcomes. And so that's really the goal of what we do in our mission. So what you see here are just some statistics that do show that, unfortunately, those disparities are only growing over time, despite lots of increases in knowledge and AI and all kinds of great stuff that we're doing in both medicine and psychiatry. Those silos continue, and they're kind of getting further and further apart, leading to these worse outcomes. And so the other thing I've mentioned here, see here is Lisa Rosenbaum has done a series of papers. My team knows I talk about this a lot. They're really good to read. They talk about how we might work on closing that mortality gap for these patients. And a big part of that is overcoming our own stigma, our own biases, implicit biases. We might prematurely think that somebody has catatonia or a schizophrenia, kind of, a psychotic exacerbation, when in fact they're actually having an MI and it's missed. So those kinds of things are, if we're working as a team and really thinking explicitly together about the biological, the psychiatric, the psychological, as well as the social determinants of health, we can do a better job of helping these patients. And hopefully you'll get to see a little bit of that. So this is just a picture to remind you of those silos. Hopefully that idea will stay in your mind and you'll remember why we care. So trying to create a bridge and really maybe eliminate those silos and actually just have us do care that's collaborative in one place in one time. Oops. So just really quickly on this slide, these are going slower than my finger. There we go. This is our mission. So kind of what we just talked about. We really aim to be a community leader for comprehensive health care that is targeted to patients with concomitant medical and psychiatric illnesses, primarily those with severe mental illness as well as substance use disorders. And we want to eventually really be seen as a national center of innovation, education, and research focused on integrating these three silos, so truly biopsychosocial. These, as a reminder, are three venues where we treat patients. So we have the largest picture there, just because we're starting with that, is Unit 19200, the Med Psych unit. We have 20 beds there. It operates primarily as a medical unit, but we have increased resources. We have access to an embedded psychiatrist who we'll talk about, Dr. Ainsworth. We have some psychology interns who spend time with us. We have 2 full-time social workers. So we really have a robust service that works to think from this biopsychosocial lens. Then we have a second inpatient unit that opened more recently, includes 10 beds focused on substance use. That's the Summits unit that Dr. Kirk Harris, our introducer, he is the medical director there. And then we have the outpatient primary care practice, which is really how everything started. So speaking of, so long ago, psychiatry had this great community health program, Strong Ties, and inpatient psychiatric units. And there was a time where we didn't have medical services. And one of the challenges that was sort of recognized by some of our key leaders, including Dr. Telva Oliveras and Eric Kane, our then chair, and Roger Boulay, a mentor of Telva's, was, hey, these patients with severe mental illness, they're coming to the hospital, they are in the emergency room a lot, they're taken care of on the medical services, but they're often misunderstood, they're sent right back out, or they leave early because they have a lot of distress and they have distress intolerance. Could we do a better job of taking care of them? And also being more proactive, so doing more preventive care. And so the idea for our primary care medical home was eventually acknowledged and created. It started very modestly with just a, as I hear the story, the lore goes that they started with just doing vaccines in the parking lot of Strong Ties to try to help with some prevention. And eventually we're able to work with the community and the department to develop a primary care practice. So MIPS has been around for the longest. And then there was another opportunity that came along in 2007, sort of a recognition that, hey, now we have this primary care practice, our patients are going to the hospital, but they're not getting that same incredible home care that they get from our team that understands their psychiatric and medical illnesses. And wouldn't it be great, we'd heard about these things called med psych units, wouldn't it be great if we had one? We in fact have some people who are dual boarded in medicine and psychiatry, like Dr. Oliveras. And so they looked at some programs at the University of Iowa and figured out a way, when some space opened, to open up our inpatient 192 unit. Started with 10 beds. Soon after, by the time I got here, it increased to 20 beds. And then a little bit later, we ended up opening yet another unit, the Summits unit, to try to address one of the needs that we were seeing was that some of the patients that we were admitting to 192 had very different needs focused on substance use disorders and kind of comorbidity, and that they might benefit from a more specialized service. And so now we have this great specialized service. So that's kind of the history. Then just want to talk a little bit about the faculty, just so that you have a sense of who we are, all are. On the outpatient side, we have Dr. Kevin Brazill, who's our medical director for the MIPS primary care practice. On the inpatient side, I'm the medical director together with my assistant medical director, Eric Bobita, for Unit 19200. And then for the substance use disorder clinic, we have Dr. Carrah. Now, we have a whole bunch of people who work on the outpatient side, including Dr. Rigney, who will be speaking today. Dr. Schiffer-Mincer is a new physician working with us, a family physician by training, and Sarah Chang is another family physician who work there. They work on that outpatient side, but they also do a lot of work with our inpatient team, which is a really unique opportunity, and that's one of the things we're going to talk about today is that overlap. So here are some of the other faculty, Eliza Pope-Collins, Alex Wood, and Eric Bobita, who work on the inpatient side primarily, and Dr. Pope-Collins also works on hospital medicine. We also are very fortunate, not necessarily part of our faculty per se, they're in another division, but we consider them part of our clinical team. Dr. Aspen Ainsworth as our embedded psychiatrist, and Kristen Holderly as our psychology. She oversees the psychology interns and helps out with psychology needs. But I really want to point out that while faculty clinicians are a big part of what we do, they're only a very small part. We, in fact, have about 40 nurses across our services. We also have LPNs, so we have RNs and LPNs. I think we have about 5 LPNs now or so. Techs, who are really important. We have 2 full-time social workers on one of the inpatient units, 1 full-time on the other inpatient unit. We are working on getting a social worker on the outpatient side. We have a care coordinator who really helps with those transitions in care. We have an embedded pharmacist, which is an incredibly important opportunity when you think about the polypharmacy opportunities and issues. Incredible group of nurse practitioners and physician assistants. We have 11 or 12 now, I believe, some of whom work part-time. And what's really important to recognize about our APP team, the nurse practitioners and physician assistants, is that not only do they work on the inpatient side and on the outpatient side, but they're also the consultants to the inpatient psychiatry unit. So anybody who's worked on inpatient psychiatry has probably met our APP team, who do consultations for medical needs and initial H&Ps. So nurse leaders, front desk staff, also hugely important. And we have a peer on the G92 unit and a really wonderful KSAC who's sitting in the audience today. So really big team that are critical to the function of what we do. And just a few pictures to give you a sense of what a great team this is. All right, so briefly, what is a med psych unit? Hopefully you have a sense now. We deliver medical care, but we're really thinking about what are the specific needs of the population who also may be in psychiatric settings elsewhere, so either have an inpatient stay or are seen in our outpatient setting or are in our primary care setting, and what are the concomitant needs medically and psychiatric. Again, utilizing this team-based biopsychosocial approach. When I say team-based biopsychosocial approach, what do I mean? I don't just mean biological people, so we have our medical team, we have our psychological team, we have our social workers, and we all talk and we do our things in our silos, and maybe we talk a little bit. The goal really is, and it's aspirational, we're continuing to work on this, but I do believe we have moved to the place where we can call ourselves transdisciplinary rather than interdisciplinary, meaning that we have overlap in our spheres. And there are times when I will be thinking about the social determinants of health and reaching out to the community, and the social worker may say, hey, did you think about whether their pneumonia is contributing to the delirium that we're seeing? So the idea that we all are comfortable and working on our trust with each other and with the patient to open up those spheres in a different way. And how do we accomplish that? We have a pretty sort of standardized approach that we use with our daily interdisciplinary rounds, where we're thinking about what are the needs that the patient has that need to be stabilized immediately. So for example, we admitted 4 patients overnight, so all of them have pretty acute medical issues. Those are gonna be the first thing we're gonna do is sort of stabilize what are the critical things. Then we might bring in our psychiatry consultant colleagues or our embedded psychiatrist or psychologist to help us think about what are the ways that we can communicate with the patient better, how are the medications interacting, what is going on in the environment where they're living, what do we know about their family. All these things are being incorporated on day one, and we're really thinking towards discharge from day one as well. What are we going to need to do now that we know that there's a new medical diagnosis perhaps, or there's a new challenge? How are we going to help this patient to adjust when they need to go home? Where do they come from? Where will they go to? And that's sort of what the treatment planning goal is of those hour-long, usually up to an hour long, to discuss all the patients who are on the units. And I just had these re-laminated again today just to remind everybody about what our roles are, what we're trying to bring to those meetings, so that we are kind of all thinking together about what we're trying to accomplish. There we go. And then what we're going to talk about today are a couple of projects that we do. We have a very robust quality improvement program within our services. On the inpatient 192 unit, we have monthly meetings that are at 6:15 in the a.m., and you'd be amazed how many people show up for that. Despite the early hour, there's a lot of engagement, and the goal is to think about all kinds of things that could be improved, anywhere from like, how do we get the linens upstairs, or how do we ensure that patients are understanding where they're coming to, that this is a medical unit and not a psychiatric unit, which is a common misconception, to building on more kind of intensive interventions that can even lead to research outcomes. So we're going to talk about two primary UP examples first. So UP is unit-based performance program. This exists across the hospital. We have them on both of our inpatient units. Many people have them on other medical units, but they also exist in outpatient settings, and it's just a quality improvement infrastructure. The two we're going to talk about today are improving admissions and discharges, and you'll be hearing from two of our nurses who have a special role. And then we're going to talk a little bit about improving communication and team education with a nurse liaison role, and you'll hear from our psychiatry interns about their experience. So I'm going to ask Stacey and Jackie, Stacey Castelluzzo and Jackie Mickol, to come up and talk about their special role around admissions and discharges on Unit 192.
Hello, I'm Stacey. I am one of the admission and discharge nurses on 192. And
I'm Jackie Mickol, and we job share.
all right, so as Dr. Wittink shared, we really came up with this role almost 8 years ago, which stemmed from our UPP goals of trying to get people discharged earlier in the day, so around 12, 1 o'clock. The idea in that is that this patient population has more resources available to them when they're discharged earlier in the day. So pharmacies are open, their primary care, hopefully it's MIPS, are open, care managers, in the hopes that they will not just come back through the emergency room if when they're discharged they have a question or they're missing a medication, stuff like that. So that was the one goal. The other goal was to help ED boarding time. So we know that when patients sit down in the emergency room, especially patients that are psychiatrically decompensated, have worse outcomes, higher mortality rates. So getting them out of the emergency room and up to the unit quicker. So from that came the initiation of this role. So Jackie and I share this role, so we are assigned, each day, and we help just streamline all the admissions and discharges. So we identify any barriers to discharge, any services or tests that are awaiting clearance, discharge medications, we help coordinate them to get them up to the unit quicker. Any equipment needs, so we're in close communication with our care coordinator, seeing what is being delivered at home, what's being delivered to the unit before they go, if they need anything before they go. So additional wound care supplies, extra clothing, food, a food voucher that we assist with social work. And then locating their belongings, because a lot of times they're all over the hospital. Or if they need clothes, we work closely. We have many people who have donated clothes to our unit, which is huge, especially for our big homeless population. So again, just taking that load off of the bedside nurse, having somebody designated to do all those things has been proven successful for our team. And then in that, we just take over all of the discharge paperwork. We go over their AVS, their after visit summary. We're able to do patient teaching in real time. Again, really take that time with the patient that they may need, answer the questions, go over everything with them. Anything I'm missing there?
Oh, that's good.
And then on the flip side of that, once the patient is gone, we coordinate admission. So we work closely with our admitting attending and then our APPs to help identify MIPS patients within the hospital that might be better served on our service. And again, the idea is if somebody is discharged earlier in the day, then we could get them up earlier from the emergency room, again, so they're not sitting in the ED or even in the ICU. Our team obviously has more resources, more staff available when they are discharged during the day than on an off shift as well.
So you'll ask what are the benefits actually of having this role, and working on a medicine unit, you can probably imagine there are a lot of things that the bedside nurse has to worry about. So if they're doing IV meds, they're doing tube feedings, they're doing wound care, all those types of things, and you may have someone that is quite sick, so you spend a lot of time in one patient's room. So to have to actually go to discharge a patient, it can be a challenge to try to do the actual teaching and those types of things with the patient. So that's one of the advantages for our role, is to be able to spend all of our time actually doing all the things that Stacey actually mentioned, getting all the items together so that they can have what they actually need. We're not only helping the bedside nurse, but hopefully we're helping the entire team, because if we can get the patient discharged early on and get them to wherever they may need to go, they may need to go to an outpatient appointment that same day, we can actually bring other patients in. And you can imagine on the other shifts, so we're primarily day shift, so we're 10 hours or sometimes 12 hours. We'll get the patients in when we can, and when there's more staff. And then that includes providers as well. So if we can get all of the patients there and try to eliminate the workload for the nighttime peoples, or at least decrease it, then it's helpful. We're streamlining the admission discharge process. So we're getting the patients settled, we're getting their rooms settled, we're going through all the paperwork, we're getting their admission vital signs. If they need tele set up, we'll do that. We'll flush their IVs. We may do wound care. We'll do the things that are pretty basic. And then we actually can offload the patient to the bedside nurse. So all they'll need to do is like a quick assessment and go forward. But of course, if we don't have admissions or discharges, we're there to help with whatever is going on the unit. One of the other things that we're helpful, her role is helpful with, is the enriched team communication. I feel like we are often a cohesive person on the team, and we can be the continuity, because a lot of times when you have attendings or other providers that are changing from week to week, we're hopefully there for all of the days that the patients are there to actually talk about what the patient actually needs for discharge. So hopefully that's helpful to pull that together to ask, have these things been addressed, or review them again? How can we get this for the patient? And then the last, which is the reduced boarding times in ED. So if we have only a few discharges, there have been times when we've been able to actually go down to the ED to get the patient, which can help reduce the ED time. I think that's helpful. I know it's overloaded down there a lot, so, and I'm sure there are plenty of other advantages to our role. But those are a few that I thought of. Thanks.
I'll just add one more thing that's really important. It's wonderful to have Jackie and Stacey in that role. Sometimes when they do get the chance to go down to the emergency room to meet with the patient, they can also explain where the patient is going and what our processes are, which really helps a lot too. So now I'm going to introduce Carrah, who's going to talk a little bit about a really cool thing that has evolved for helping interns learn about our team.
So for our Nurse Shadow Day, this is a main part of our nurse resident liaison role. This started years ago before I took it over, and the main purpose was to improve the communication between nurses and the interns that are coming into our unit. Sort of what was mentioned is we have the same APPs, attendings, social workers, care coordinators that we're working with on a day-to-day basis. And then we have the residents that are coming in and just popping in for a couple weeks here and there. So we want to make sure they feel welcomed and they're able to communicate with us, and we can communicate with them at the same level as our providers that are strictly on the unit. So before their first day on the unit, I send them a little welcome email, and they get a pre-rotation survey asking about their comfort communicating with different team members and how comfortable they are with medical equipment. And then on that first day, they come in and they get to see our nursing report in the morning. So they see what information we're communicating with each other. And then they do a little shadow, which this has adapted over the years and changed based on what we've found is helpful for them. So they get sort of like a little orientation tour to the unit. They get to see like bed alarms, IV pumps, chair alarms, telemetry, and get to meet different members of the team, which is really helpful to hopefully make them feel as welcome as possible as soon as they come on the unit right on that first day, first few hours there. And then something new that we've added with this last rotation is then sort of passing them off to the APPs afterwards. So like Cyrus and Lorraine have been super helpful and spent many hours with them going over things that we've identified from previous years that they need a little more assistance with. So with the discharge planning, what's expected of them on a day-to-day basis. We talk a little bit about UPP as well. And then afterwards, I send them a post-rotation survey and ask mainly the same questions. And then we also hear, what could we have improved on? What did you need more information on? How could we have better supported you? And we've heard really great feedback in the last few years that I've done this. They tend to report that they feel a little more supported than on their other rotations. They feel very welcomed. They feel like we have good communication with one another. 100% of the residents have said that having the nurse shadow day was helpful for them. And hopefully at the end of the day, having better communication and collaboration can provide better care to our patients. You guys.
So next will be Dr. Kim and Dr. Oliver, two of our PGY1s who are going to talk a little bit about their experience, and they happen to be on service right now.
Okay. So Dr. Wittink just asked us to speak a little bit about like what we've learned on the unit and how the kind of like collaborative team environment might feel a little different than some of the other services we're on, because in our first year we obviously move around the hospital quite a bit, so we get exposure to a lot of different ways of doing things. And I think the thing that I noticed the most about 192 in compared to like my regular hospital medicine rotation is that I find that more of the patients on 192 often need like more emotional support and need like more of a kind of compassionate approach. And I think this makes me think of one patient that I had recently who I think I was discussing this with my attending, Dr. Bobita, and we were discussing how some of the patients on 192 might just be like coped out. Like they've had to cope with so much for all of their lives that even if they do have good coping skills, that just using them all day, every day, eventually they kind of reach like a breaking point. And I think I've experienced that on 192 a few times. And it was this kind of classic thing where the patient doesn't really tolerate uncertainty very well, which is understandable. I don't think many people are really super happy with uncertainty, and the hospital is this kind of very inherently uncertain place. And we were just trying to get this one test done so that we could just get things set and done with this person and hopefully get them home. But it was just such a struggle. And on this last day we were trying to get it, we were like, okay, we're almost there. The patient is about to go to MRI. Life is going to be okay. She's going to go home. Things are going to be good. And then one of the nurses comes and tells me that the patient is just like really dysregulating, just like having a really hard time out in the milieu. And I was just like, okay, transport is coming. We're almost there. We can make it. And I am just like so frazzled though, because it's like I was on the phone with MRI and I was just trying so many times the previous days to get this done and it didn't work. And I just went to the patient and I was like, look, transport's almost here, all these things. And the patient just blew up in my face. And I just made all of the classic mistakes when you're trying to de-escalate someone. So I did everything wrong, essentially. And the patient was like getting worse. I was watching the train go off the rails, and I was like, oh my God. Now I'm going to be the reason that this doesn't happen. But one of the nurses was there with me. Her name was Morgan, and she did everything right. She was super compassionate, like slowed the pace down, just really reflected and empathized with the patient. And I had to go call MRI to try and buy us a little more time. And by the time I got back, this patient who was like screaming in my face not 10 minutes ago was like lying very calmly in bed. And Morgan was just like, okay, you know, we're going to walk down to MRI. Everything's going to be good. And so I think that was a great learning experience for me of, you know, because you can watch like all of the like de-escalation modules that you want, but like in the moment, it's really hard to practice, but it's really helpful to see someone who's like really good at it and then be like, oh, this is what I should try and do next time. So I think that was really helpful learning experience. That was really facilitated by having a closer relationship with nursing.
So as was alluded to, you know, we rotate off a service on various services, including hospital medicine with the medicine resident teams. And, you know, one observation I've had is that sort of through MIPS and through having a nurse shadow day and our interdisciplinary team meetings, you know, we foster a much closer and like more productive relationship with all members of the team. Including nursing, including the APPs and the pharmacists, and it leads to a lot better care. You know, there were times on my off-service rotations where, you know, I didn't really know who I was speaking to, like where I would send a chat and it felt like it was going into the ether. Whereas on 192, like if I had a question, you know, I could send a chat, but I could also just go and find the person and have like a productive conversation in person. And almost always that like led to better care. Being able to go to our unit pharmacist and ask her a question in person, it just leads to a much better working environment where everybody, I think, can feel heard. We can bring up concerns and not have it be like a hostile thing. You know, if people have questions, they can ask each other, you know, like, why are we doing this? Or if they have different ideas, we can all kind of discuss them. And, you know, as Paul kind of had that example, I think ultimately that leads to a much better like working relationship, but also ultimately better care for our patients who are more vulnerable, who can be more challenging behaviorally, and require that kind of biopsychosocial team-based approach. And I'm really grateful, you know, to be able to work together with everybody and learn from them in a way that's really collaborative and great. And I like knowing the people that I'm working with and knowing what their faces look like versus the sort of faceless e-record chat that I've often had to experience with, you know, as an off-service resident.
Thank you both for telling those stories, which are really rich and very illustrative. So there are a couple things that are on this slide. One of the last things that I just want to mention, and that will be a great segue, is the interns spend 10 weeks with us on this service. Sometimes it's usually not 10 weeks at a time, it's different weeks at a time. But they also, during the rotation, spend 1 day a week going to the MIPS primary care clinic. And so that was a good segue for us to talk a little bit more about MIPS primary care. So Dr. Brazill.
Thank you, Dr. Wittink. Thanks, everybody, for coming. I'm going to steal Dr. Kim's coped out concept because I really like that. So I was thinking about when you were saying that, I thought, okay, so God, look at all this stuff that these people have around them to get through the hospital, to get discharged, hopefully in better care. So the average person who comes to us at the MIPS outpatient clinic is very similar to the person who is admitted to 192 or G. These are people who have usually been diagnosed with severe mental illness or chemical dependency or both. And so the average psychiatric patient has hopefully a psychiatrist or a psychiatric NP, a therapist, a case manager, maybe a care manager, somebody who can help coordinate transportation, hopefully a primary care doctor, maybe a social worker who follows up, maybe an OAR team member who has sort of adopted this person who said, oh, Jim can't ever get here on time, I'm going to call and make sure. We have an embedded endocrinologist at the outpatient clinic. These people have a lot of needs, but it's because they have a lot of needs. And so it's understandable that they would be sort of coped out from time to time. And then the team members like all of us up here and all of you in the audience who are taking care of folks who have severe mental illness plus medical issues, it can be very trying. And so one of the things that's so great about this division, and I think the department, is that we really work pretty well together. So rather than say what our mission is, it's exactly what Dr. Wittink said. We all are working together to take care of the most vulnerable population of people who are living in our city and the surrounding areas. The people we see on TV who get into scuffles or who may have been stabbed on a bus. These are our patients. Many of the people that you see on TV are people who have been victims of crime or who are very dysregulated and misunderstood. And so one of the things that we do is to try to make a home for these folks. And so that's why we're embedded right at the Brighton campus. So we're the teeny little sweet bee in between our partners at Strong Recovery and Strong Ties. And those are our patients, right? I think it can be confusing sometimes because we're medicine and psychiatry. So we must be a place that takes everyone who has a mental health issue. And it would be great if we could. But really what we focus on at MIPS are people with severe mental illness, schizophrenia, bipolar disorder, major depressive disorder with psychosis, severe anxiety disorder, severe personality disorders. You all know what a severe mental illness is, as well as chemical dependency problems. And so while we would really love to be able to take care of people of all walks of life who have different psychiatric illnesses, we really are focusing, particularly since we've become a division, on folks with severe mental illness. So if you have people who you think would be a good fit for us, you can send me an email or send me an inbox and say, hey, I've got a person, they don't have a primary care doc, but they're linked up with Dr. Reddy over at Strong Ties. Would they be a good fit? And usually the answer is almost completely yes. If they go to Ties, if they go to SRCD, they go to Strong Ties Young Adult, they go to Schwarzkopf, they go to On Track, which is our RGH, kind of like, it's similar to Strong Ties Young Adult over there. So those are the folks that we take care of over at MIPS. We have an on-site lab that's open from 8 to noon every day. And we have great partners in that if we're having an issue with somebody who has, maybe a difficulty with accessing a certain medication that is not a medication that we prescribe, we have an on-site pharmacy. And the pharmacists that we work with are fantastic. So I'm grateful that we've got the interns who come over and rotate. This is our second year. The current second year residents were our first class that came through the MIPS outpatient clinic, and they did a wonderful job. And our current intern class is doing really, really well too. So where does the little small primary care office fit into this whole thing? In a lot of ways, we're kind of like the buffer and between the psychiatric world and the inpatient world when people need to go in. So when we get new patients at the office, we always say, we have a special unit that we take care of our folks in the hospital if you're having problems with a medical issue. So the people who are on 192 are people who are having medical problems. It's a medical system, but all of the patients have concomitant, pretty severe psychiatric issues. So we're kind of the launching pad for getting into the hospital, and then when they leave the hospital, they come back to us, hopefully. Now, everybody on 192 is not a MIPS patient, but the team is so great on the unit, they always say, hey, who's your primary care doc? And if they don't have one, we try to get them linked up with us if they've got outpatient psychiatric care. So for the most part, as has been mentioned before, we're mostly primary care. I'm a psychiatrist too, and I'm a psychiatrist for many of our patients, usually folks who've graduated from TIES or graduated from SRCD, folks who are stable. But we have a nice relationship with our partners that say, hey, Mary is not doing well, and we've tried some changes. Is there any way we can get her some more robust care? And that's been really a great way for us to kind of work together with our neighbors. Anybody has any questions about primary care within the division, please just shoot me an email. Easy to remember, last names like the country, but with 2 L's for whatever reason. All right, that's my little spiel. I will hand it off to Elaine, my colleague.
Hi, everyone. So my name is Elaine Rigney. I work both on 192 as a hospitalist and in the MIPS clinic as a primary care doctor. And this is my 4th year being here, although I did my training in medicine here, so I had some familiarity with how our system worked. But when I started here, my role was unique in that I was kind of, literally in both settings. And I found that while we did have a lot of great communication and collaboration, something that could have helped more was to really directly talk from the inpatient team to the outpatient team. So one of our quality improvement initiatives at the time was to have a weekly meeting every Friday on Zoom where we invite the inpatient providers to talk to us during our scheduled outpatient meeting to discuss the patients who are currently admitted. And there's where we could really get a lot of good information that might not be very obvious. Like, for example, maybe when the patient was admitted, the week before, they had broken up with their girlfriend who managed their insulin. And that maybe clarified a lot on why the patient presented with DKA, that the patient might not have communicated with us, or for things like the patient's baseline, is it normal for this patient to not want to share anything with us, be very cagey about certain things? Or then the answer might be, no, this patient's normally very, open and conversant. This is something that really should be addressed. And then we also, since I've been hired now, Dr. Mincer has a similar role to me where she's also in both settings. So, we've been doing a lot of collaboration, and I think that I can say that anytime a patient's admitted or when we're going to send a patient in MIPS, it's very easy to communicate with the providers who are going to be involved. But while we're really good at talking amongst each other, and I think we all have a shared goal of wanting to get the patients better, healthier, in a realistic way, it's sometimes hard to know, what do the patients think? Is this also their goal? So what we've done more recently is we actually applied for an internal funding and got it. And we wanted to take this time to really assess more of the patient's voice as it pertains to the discharge process. So this comes from trying to assess what we call their priorities. And I'll talk about that in a little bit. But the goal of our initiative is really to get the patient's understanding on what they need when they're discharged from the hospital and what we can act on for them. Because oftentimes clinicians will either under or over estimate or what they think the patient's abilities are and what the patient's needs might be. And sometimes it's better to just ask them directly, but there's not always a great way of doing that. So Dr. Wittink, she had actually done some research previously in the primary care setting on something called the doorknob phenomenon. So, let's say you have a patient in their outpatient office, the PCP thinks that they're getting all the important stuff discussed. As they end the visit, they walk out, their hands on the doorknob, and the patient says, oh, wait, I also want to bring this up. And generally, that's probably the most important thing that the patient wanted to share. But now, the PCP has maybe 30 seconds to try to come up with a plan, or they're going to be running late for, their next visit. And it was a real missed opportunity where had they known that that was what the patient wanted to discuss from the onset, they could have done a lot more to help them in that time. And there's, a lot of barriers in patients being able to express this. So sometimes there's power asymmetries, there's different boundaries in care. The way that hospital and outpatient clinics are run tends to be very much, for us providers, we have our schedule, we have the time that we round on patients that might not always be the best time for the patients themselves. So we wanted to come up with a tool to meet the patients and understand a little bit more what their priorities are. So this is what it looks like. We were really fortunate to have some really great research assistants who would go into the room with the patient and do this tool. It's on an iPad, and it works like a card sort tool, but digitally. So we'll ask the patients what's most important to them, and they'll have options. These options were actually developed from a focus group earlier on things that might be important as they're in the hospital and thinking about how things are going to be when they leave the hospital, because it is discharged focused. So it could be things such as managing their medications, feeling safe, doing things on my own, or something else entirely. And we start by asking them to rank by what's most, least, and kind of in the middle in importance. And for that way, we can really have the patients engaging with what they are instead of just picking their most important right off the bat. And all of this is facilitated with the research assistant. So if there's any confusion or literacy issues, or they want more discussion, there's someone there to conduct it with them. So they continue, as you can see, to kind of pull over their items. And then our goal is, after we have all this, is to be able to share this with anyone who's going to be taking care of the patient. So finding a way to kind of integrate it into our e-record. We don't quite have a patient priorities tab, but we are fortunate in that we were able to input it into a flow sheet. So the research assistant would then take their priorities as well as an explanation from the patient on why they were most important. And then that would be documented into a flow sheet. And anytime that was used in what's called a dot phrase, where you would it can pull in from the flow sheet into any text of any note that you would like. So we revamped our discharge summaries as well as discharge instructions to be able to share that with anyone who is going to read the discharge summary. And then the discharge instructions, these are things that the patients or family members will have on hand when they're discharged from the hospital. So this is kind of the exact wording that we use. So it basically will take, the yellow part would be whatever was written from that flow sheet, and we'll put it into the discharge summary. But if you guys are anything, oh, here's also just what it would look like in their discharge instructions. So we changed the pronouns there. But if you're anything like me, it's a lot easier to learn from a concrete example. So here's a case of a patient. So this is a MIPS patient. He had been admitted a couple times, and he was on our unit. He's 68. He has schizoaffective disorder on Clozaril, has your classic comorbidities of diabetes, obesity, BPH, also heart failure. And 2 weeks earlier, he was also in the hospital for an ileus, and he had a UTI at the time, went home. This time he came back with Fournier's gangrene, which is a very serious genital infection that requires surgical debridement and antibiotics. And earlier, before he was admitted, there was consistent hygiene concerns coming from the patient's facility. He was in one of the DePaul SPOA homes with the PCP. And the PCP would even say, you know, he would look her dead in the eye and say, oh, I showered today. And there was absolutely no evidence that the patient had showered. So when he came to our unit, he was treated. He had a very normal management course. Everything went well. He did the priority survey, and in this one, he identified something else. And when we asked him what that something else was, he said getting better, healthier, and staying clean. And part of that included taking a shower and getting dressed. And when we have patients who participate in priorities, we'll try to bring those up in our care planning. So sometimes this can kind of be revisited with the patient, and as well as on their discharge day, we remind them what their priorities were. And here, you might be, this is the hospital discharge summary. I know you can't really read it, but I thought it was important to see, you know, anyone who looks in e-record can see hospitalization summaries from patient admissions. And here we have it pulled in, so every priority is shared with the PCP or anyone else who's going to be taking care of the patient outpatient. So in this one, it says in the hospital, the patient participated in the priorities tool, identified as most important as something else, taking a shower, getting dressed, important to stay clean. So when he came for his post-hospitalization visit at MIPS, the provider was able to talk to him a little bit more about that. And he actually found out that the patient was, you know, taking hygiene much more seriously, and they used that as an opportunity to educate about wound care. And this patient, he actually was not readmitted for, I want to say, like multiple months. And then his most recent admission was nothing hygiene related. So now lastly, I just want to share a little bit of our data from the surveys. So when they're sorting from the most somewhat to least, most patients are finding that on our unit, understanding their health is one of their most priorities, second to managing medications, feeling safe, doing things on their own. But the vast majority of them will actually say that their single most important is something else, which we think is really good because the patients then have, you know, the agency to share what is most important to them. And I paraphrase kind of what those elaborations were. And for a lot of patients, it ended up being sobriety. And then second to that was family and safety, and then just their overall health. And then for some, it was things like mobility, employment. So we're really happy to be able to, you know, get a little more of the patient voice in our discharge process. And some next steps are now on more ways that we can integrate this. So it's not just here in the hospital. We've also started to ask patients what their barrier is for possibly, you know, attaining that priority. And if there are things that we can do, we'll help them. You know, certainly the way that things are, we don't always have the resources for certain problems, but we'll at least try as best as we can. And that's it. Thank you.
Okay, thanks. We have a few minutes for questions. I think there are some microphones in the room for people who want to ask questions here. And we have a few things in the Zoom while we wait for that.
Hi, big fan. It's good work, right? So thank you very much for this presentation. I always appreciate when I see like quality improvement things all nicely and folded in. My question is there kind of comparative data that this team or division looks at when you compare integration of medicine and psychiatry to sort of longitudinal outcomes? Like, I know it sounded like, it started with MIPS, it started kind of small and it's grown since then. Do we have data that shows kind of how our patient population compares to a more bifurcated approach in terms of like physical health outcomes, mental health outcomes? And if so, where's your next adventure in that respect?
Yeah, great question. So this is supposed to be the clinical rounds, not the research rounds, but we will delve into that because it's quality improvement. So we have 2 papers out and another one that Dr. Lee really wants me to get out soon that show that we have better outcomes in terms of length of stay and readmission rates when we compare similar patients. So we're able to do this. It's not perfect, but we can do this because we can say, we only have 20 beds on the inpatient 192 unit, 10 on the other unit. So there are our patients who are admitted elsewhere, and we can do a comparison of when those patients end up somewhere else versus on our unit, and we're able to see that we do have those kinds of outcomes. So health outcomes that are related to more the health system. What we don't have as much data on, although we're working on that, is outcomes that are really health related for the patient. So is there better hemoglobin A1C, things like that. We have a second paper that was focused on the outpatient setting, so the MIPS primary care setting. Dr. Joy Choi was the primary author on that, and Dr. Kevin Brazill was a part of that study as well, looking at outcomes specifically related to cardiovascular disease, and we do see benefits of the primary care integrated setting for those outcomes as well.
Yes, thank you for the presentation. I have a question about patients who are currently with other primary care providers in our region or community. Some of those patients have serious mental illness, really serious mental illness, schizophrenia. Some of them are getting injection medications. And the primary care providers are struggling with the medical care as well as the psychiatric care. Traditionally, we usually get those phone calls and try to refer them to a psychiatric clinic, but I'm wondering if there's an opportunity to provide consultation or maybe adopt those patients medically from those providers who are really struggling. Can you speak to that, Dr. Harris?
Thanks, Dr. Nazra. So good questions, a couple things. It would be great if we could, I think one of the things that we hope to be at the MIPS primary care office is sort of the go-to place for medical care for people in the region with severe mental illness. It's difficult sometimes to also provide their psychiatric care because of the enormous amount of wraparound services that folks need, a therapist, a case manager, et cetera. So a consultation sort of service would be helpful, but one of the things that I also think is helpful is teaching primary care doctors how to manage psychosis and psychiatric illness in their settings because there's just not enough psychiatrists. And so a couple weeks ago, I made a presentation at the New York Society of, or Academy of Family Physicians in Lake Placid on teaching primary care doctors how to manage psychosis in the primary care setting. Teaching them a little bit about long-acting injectables. How do you transition from oral Invega to injectable Invega? Because based on kind of what you've said in my experience, it's like there's so much need and MIPS can only absorb so much, particularly if we don't have the psychiatric partnership. That's kind of an approach that I've taken. I don't know if anybody else has any other ideas, but that's kind of where I'm looking at things. I know that you and I are kind of working closely together to try to address these things, but that's kind of where we're looking at from the MIPS perspective.
I think the other thing is just having the resources, so having enough physicians, providers who can do this work. So again, the education piece is really critical, and I'll just put in a plug for our fellowship. So we would love to hire and train more primary care physicians and internists to do this work so that we can sustain this beyond our team here.
We also have a question and some comments in the Zoom. The question is from Marsha's portion of the talk, that we would love to hear more about the peer support component that you mentioned as part of the team. And is this a trained peer support specialist? And what potential that has for addressing social isolation and loneliness?
Lots of potential. I think it would be great to have more peers. We have
only had the peer on the G92 unit, so it's actually, I might bounce it back to you, Dr. Harris. I've seen incredible impact of having a peer and having that perspective just a little bit closer to the patient view of what the reality of working within our health system is, or being within our health system. It is something that I would love to move towards, having a SMI peer on our inpatient setting. But one of the challenges is always, how do we fund these things? And getting our hospital to pay for another body is always a business improvement plan, as we all know.
Yep. Yeah, to answer the question, our peer support specialists have been trained and certified peer specialists. What we've worked most closely with is a substance use peer on the G92 unit. And that's been invaluable both for liaison work with staff and setting up protocols for the unit that patients are comfortable with, but also translating patient expectations for the hospitalization and helping us to really weave together what it is that patients would like to do with their time in the hospital. Okay, thank you, everybody.
Not so much a question, but more just to say that as someone that's worked in the outpatient setting, way back at Strong Ties, and then inpatient, interacting with patients that have touched MIPS from both sides, just want to say that it does make a huge difference, and it is unique and very meaningful. So not a question, but more just thank you. That's all.
Thank you. And we are really, grateful to the hospital for kind of believing it. As Marsha had mentioned, there's not that many places like this, and we don't do it perfectly, but we're always trying to improve. So, this is sort of a unique thing for the University of Rochester to have, and we're lucky to be able to do the work. And I know you guys are all part of it. So, thanks. All right, thanks you guys for coming. Appreciate it.